Thank you. Yes, as Ash said, I think I know most people here, but I'm Amalie Dyda and I'm an infectious disease epidemiologist. And today I'm going to talk about HPV vaccine coverage in a study we did investigating the exposure between the vaccination coverage and possible exposure on Twitter. So I'd like to start by acknowledging the traditional owners of the land on which we meet today, wherever that may be, and pay my respects to elders past, present, and emerging. So as Ash said, today I'm sort of going to be talking about the merging of computer science and public health. In my sort of work as an infectious disease epidemiologist, I specialise in vaccine preventable diseases and vaccines, and that's certainly where my PhD work started or was. And then post PhD, I started working at the Australian Institute of Health Innovation with Associate Professor Adam Dunn, Professor Enrico Coiera, and it was working on a project that was really trying to merge computer science and public health together. And it was really, I think, hopefully the start of an exciting journey for me, because I really sort of fell in love with data science through that process. And it's really where I hope to lead in my career. Having said that, I would like to start this with a caveat that I'm in no way a data scientist. I'm very much the public health expert in this work. I'm purely working with the very amazing computer scientists who did a lot of the analysis, or all of the analysis. So I thought, I don't know how much everyone knows about sort of different diseases in public health. So if anything I'm saying is sort of too simplistic, please let me know. But basically, this is focusing on HPV vaccination, and HPV is a group of viruses. There's a lot of them. There's more than 100 types. They're predominantly spread via sexual contact, and they can lead to high-grade cervical abnormalities, which then lead on to cervical cancer. And there are two specific strains of the virus that cause the majority of those cancers. So it's really something that causes severe illness and fatality in people. But there was good news in recent times, and they found a vaccine that would actually help protect against HPV. And so the National Immunisation Program, which is Australia's national program, who decide who gets what vaccines and what they're going to fund, added HPV vaccination to the formal register where people can access it for free. And it was introduced for adolescent females in 2007 and adolescent males in 2013. And I just wanted to flag that it's a 3-dose vaccine. So people don't just get one and they're fully vaccinated, much like COVID where you need 2. People need 3 doses before they're considered fully vaccinated. So the HPV vaccine in Australia and worldwide has really been a success story. And this graph really shows what's happened to cervical abnormalities since the introduction of the vaccine. So you can see where the vaccine was introduced here. And you specifically in those younger age groups who perhaps, who were eligible for the vaccine and hadn't been exposed yet, you can really see there's been a significant decline. And I guess just based on some discussions with Aminath, I wanted to sort of highlight the different kind of data that we use. So obviously with this vaccine, we're trying to reduce cancer mortality, but as that's sort of a really long-term thing, we use the high-grade cervical abnormalities as a measure in between to see, while we're waiting to see the cancer rates go down, we can use this as an indicator. So a lot of times in public health, we use, I guess, what we would call indicator data, which perhaps isn't exactly what we want to measure, but gives us an idea. And this really shows cervical cancer incidence in Australia, and that dotted line is where we are, and the full line is the target we need to reach for elimination. And we have lower rates, but obviously this is affecting different people differently. And particularly, I just want to highlight that in Aboriginal and Torres Strait Island populations, we're nowhere near that elimination target, and we still have a way to go. So vaccination is still really important in this ongoing sort of health issue for Australia. And this is how many people have been fully vaccinated. So you can see that they're pretty high. We've generally got rates of around 70, sometimes 80%, but that does differ by region. And again, there's a difference between Aboriginal and Torres Strait Island women and non-Indigenous women. And again, we're still falling short of the target. So when you think about childhood vaccinations, the very young vaccines that we get, we have very high rates of coverage, so somewhere up around sort of 98% generally. So there's certainly room for improvement in our vaccination coverage for HPV in Australia. So why do people not get vaccines? It's a complex question and answer. And basically it depends on the vaccine and the age group. But certainly for this specific vaccine, one of the really high contributing factors is the parents' attitudes and beliefs around vaccination. And so traditionally in public health, what we've done, we have, when with COVID, when you see on the news, they say we've had this much, there's this much coverage of COVID vaccines. So we actually have a register where doctors and immunisation providers have to report what vaccines they've given. So that's how we measure vaccine coverage. It's called the Australian Immunisation Register. But then for things like attitudes and beliefs, the information on coverage is very limited. It's yes, they've had the vaccine, or no, they haven't. If they're not in the register, we assume. But the attitudes is something that's a bit more difficult. So traditionally in Australia, we just have to run surveys, really large scale, expensive, slow surveys. And I think particularly, I started all this work. It's, I love vaccination. I could talk about it all day, but it's always been important. But I think particularly with COVID has highlighted that there's been that real change over time in a really quick time period, that it's very hard to keep up to date with large scale surveys. And so that's where social media comes in, and why we decided to look at social media as a source to maybe measure people's attitudes and beliefs. So obviously the internet has exploded. Around 80% of people now have social media profiles of some description, although I am told that the young people have them, but they don't use them. They just use them to message their parents and things like that. So obviously different platforms have different, demographics. But what this has really done is created I don't want to say a new problem. Misinformation's always existed. I don't know how many of you know, but certainly in the vaccine field, there was a famous study in the 1980s by a guy called Andrew Wakefield, and he, published a study that was basically fraudulent, that, suggested that the MMR vaccine was linked to autism. And that has just been really pervasive. People still quote that research today, even though it's been completely disproven, and he's no longer allowed to practice as a doctor. So misinformation has always been an issue for health, but what the internet has done is really allowed that spread to, basically anyone, and increase people's possibility of being exposed to that kind of information. So some previous work that had been done by the group had sort of been starting to look at these correlations, and I think there's a lot more work that could be done in the space, but I'll touch on that at the end. But basically it had showed that if we looked at who people followed, we could generally predict their opinions, and that if people had previously been exposed to negative information, then they were more likely to post negative information in the future. So that's, that's quite common sense, I guess. It makes sense. So we really wanted to see if there was a correlation or an association between what people were exposed to on Twitter compared with the coverage. So this was population level. It's not individual people being vaccinated. It's how many people are covered in a specific the proportion of people covered in a specific district. And I think the aim here is really important. And I think this is really one of the things when I think public health and computer science work together. It's important to understand why you're doing that kind of work or that kind of study. So really, how will this information be used for public health? And for us, we were really looking to see if this could be used as a flag. So I'll go through it later, but there are some biases through the data. But if there was an association, could we actually use this information in public health to flag different regions that might be at risk of having lower coverage, so that we could put targeted interventions into place? So I think really understanding how you plan to use the information before you start is really key because it impacts on your methods and what you do. So basically we searched Twitter using keywords. They were all related to HPV vaccine. And this is an older study, but it's very similar to some work I want to do, which is why I'm presenting it today. So it was 2013 to 2017. And then we extracted information about the people that tweeted the HPV type information, with all the sort of regular kind of information, timestamp, URL, but also their followers, so who possibly could have been exposed to that information. And I think that's one of sort of the key unique things about this study, is that we didn't just look at the spread of how many people are posting, but we actually looked at how many people might be exposed. And sorry, I think some of you have heard me use this example before because I use it a lot, but we care about who sees the tweets and not just how much is being posted. Because if I post something, maybe 50 people will see it on a good day. But I don't know, if Britney Spears, I don't even know if she's on Twitter, but if she tweets something, it's going to have a much greater reach. So looking at the number of followers is really important. And then these are all the parts I didn't do. So I'm just going to explain what was done. And for further information, I'm happy to provide the paper to anyone. But nominatum was used to extract location information from all the followers of those who posted about HPV sort of related information. And then we used topic modeling to group the tweets into positive or negative sentiment. So we also used a number of other data sources. So the geographic regions we used for vaccine coverage were primary health networks. And for those of you who don't know, so a primary health network they're basically independent organizations that are supposed to streamline access to health services for people, particularly, I guess, marginalized or underrepresented populations. So really trying to improve the health of vulnerable populations by enhancing their access to primary health care. So those were the locations that we used. And then for any primary health networks that sort of cross boundaries, if there's like a South Melbourne and a North Melbourne, they were aggregated, as usually Twitter users don't say I'm in South Melbourne or North Melbourne. They usually just say Melbourne. And then we also used information from the ABS to look at some economic and employment factors for those people, and that information was allocated to the regions as well, so they could be characterised in that kind of way. And then obviously we needed to compare this to vaccine coverage data, and that was provided by the National HPV Register. So that's really part of the Australian Immunisation Register. It feeds into it. So we applied for data and they let us. So it wasn't publicly available information. So we used unsupervised machine learning and topic modelling, which I thought sounded really fancy, but Ash tells me that it's, he says it's easy. So maybe one day I will know. But based on previous research, we selected 30 topics as our sort of limit for topics. And then to evaluate the, quality of how the tweets were allocated, we did intrusion tests. And I don't know how common this is in machine learning. So if this is very basic, I apologize. But basically the intrusion tests were getting a number of experts. I was one of them, and giving us a series of 3 of the tweets in a topic, as well as 1 from a different topic. And we had to basically go through and try and pick out the tweet that didn't belong to see how good the the differentiation between the groupings were. So we used that information to actually look at how well the information had been characterized, but then also to develop a hierarchy. So we didn't just have, a number of different tweets of topics. We said, these are the really pro, these are really negative, and sort of put that in a hierarchy. And then we basically labelled each tweet with one of the topics that had been defined and allocated this to followers of people who had posted that information to get, estimates of possible exposure. And I guess I feel like I'm saying a lot of the limitations I'm going through, but just because someone follows someone doesn't mean they've necessarily been exposed. So this is an estimate. And then we aggregated that to one of those regions that I talked about, the 25 primary health networks. And then I've got here, which produced a measure of proportional topics, which resulted in a set of 31 potential factors. So even though we had originally 30 topics, there was a subset of tweet, like an extra set of tweets that had 3 or less words. So we ended up with 31 potential factors. And then we used elastic net regression to model the HPV vaccine coverage across the 25 regions with the 5 socioeconomic factors that we had from the ABS. And the models were produced for both males and females. So I guess there are, because the boys program was introduced later, coverage is lagging. So we do really need to stratify that information when we're looking at to see what's going on in the different genders. And we looked at full dose vaccination. So only people who'd had 3 doses, not people who'd had 1 or 2. And then reported correlation between observed and predicted values and the coefficient of determination. So overall, we had over 600,000 HPV-related tweets, and that was from over 200,000 unique Twitter users. And then of the people that followed that, there were over 200 million accounts. And then this one is when we start to see some of the limitations coming in. So only around 30% of those could actually have the location inferred. So the users, only around 30% of the people who were possibly exposed, we knew where they were. And of those, less than 1% could actually be, I guess, allocated to one of those specific regions that I talked about. So we still had a large sample size at the end. Well, large for public health. It's probably not large for data science people, but we still had over 1 million tweets within the analysis. And what we really saw is that the potential exposure ranged across states, which I think you've seen in other studies based on what Amalie told me yesterday. But certainly we saw the most in Sydney. And this is our hierarchy. So as you know, when I mentioned the intrusion test, so we allocated the different topics. And so from this side over, these are the most negative, sort of mid-negative and neutral, and then the most positive, mid and less positive. And really, when you look at these end ones, it's nothing surprising. These are really the hardcore conspiracy theory type messages. These are more, less conspiracy theory, this second group, and more individual reports. So people saying, I had a vaccine and this happened to me. And then this in-between one was more just sort of mixed discussions. And then the same for the positive. So a lot of these very dark ones here were, from, health promotion organizations, so very much pro-vaccine. And then the second one is more about new research or information coming out about HPV or HPV vaccination. And then the last one, again, has that sort of mixed discussion in there. And so before we looked at the associations, we actually looked at the tweets over time. And I do love this graph because all of those peaks relate to specific events. So, I guess when like a celebrity tweets something about influenza tweets go up, Google searches go up, but these green peaks really correlate to when new research was announced or when there were good news stories in media around the success of the HPV vaccine. And then these ones down the bottom were more related to, so one of them, sorry, I forget which one is which, but one of them was around people reporting adverse events. So I don't know if everyone remembers, but in Australia, when the HPV vaccine was first introduced, there was some reports of, fainting and adverse events occurring after people had had the vaccine. So when that kind of stuff was in the media, there was more information about that. And one of them also relates to Katie Couric, who I believe is an American TV person. And she ran an episode of her show and actually had like an anti-vaccination type person on. It was very sympathetic. And it really, that TV segment really got a lot of attention. So what we did find is that there was definitely a clear difference between the different cities in terms of what topics they were being exposed to. And there were a high proportion of the negative type exposures in the, generally in the, in the regions that had lower coverage. So certainly the Gold Coast is a good example of that. They had a high proportion of negative tweets and they've got low vaccination coverage. But then there were also some that just sort of had nuanced information. So for example, you could see Cairns has negative, but also a lot of positive. And I would say it's hard to see from this map, but they sort of have mid-range kind of vaccination coverage levels. So really, I think that the big finding is more that we could find the specific differences of what were being sort of shared in different regions, which may actually have implications for public health. That it wasn't actually something we were looking for. But overall, the models did show the topic exposure was more closely correlated with HPV vaccination in the models that included the HPV vaccination, as opposed to the models that included only the economic or education type variables. And as I mentioned, there are some of those specific nuanced differences. So there are some limitations. I think I've touched on some of these as we've gone through, but obviously Twitter is not a representative sample of the population. And again, I think this really comes back to the aim of what we're trying to use this for. So I guess the original idea was really, as a flag, we didn't necessarily want to say specifically, this is how many tweets are happening in this area. So this is the coverage we would expect. If there was an association, it was more of a flag that, hey, you know, there might be some low coverage in this area that you might want to address as a public health professional. So in terms of, for that purpose, in terms of representativeness, it's less important. And then obviously this is only the type of information people are exposed to on Twitter. They get exposed to information in a number of different ways, and it's only for people that are on Twitter. And as I mentioned before, and as you all know, you know, there are different demographics of different people on the different platforms. And obviously there was a big discrepancy between the number of followers and also those that we could actually allocate to a region. And also we didn't include any people who were suspended or deleted their accounts, although that was a smaller number. So overall, we did find a significant association, which I think definitely suggests that we could do more work in this space. And that monitoring perhaps the specific information that people are seeing in different locations, instead of just using it as a flag, we might be able to have more targeted health promotion campaigns. So I'm guessing health promotion isn't an area of expertise for most people. So we don't tend to just, you know, there are large scale statewide sort of health promotion campaigns that say, go and get, you know, a vaccination, but there are also smaller targeted campaigns at the local level that come from, you know, public health units or the local government. And those are the types of campaigns that we could really target specifically. So if one region was specifically getting information about, I don't know, I'm trying to think of something that's common with vaccinations. If they were getting a lot of information about vaccines containing mercury, which isn't true if anyone ever says that to you, then that could be one of the myths that they could actually address in the campaign if they knew more people were sort of spreading the word. And that nuance is really important in public health, because a lot of the outbreaks that occur are very localized, and certainly it's not HPV related, but when we see outbreaks of measles, it's generally because there's a specific population or subgroup who have very low levels of vaccination, and it's really circulated within that small community. So where to from here? I am very excited about this area of research, as I unfortunately learned from yesterday. I get a bit overexcited, but I just think this has the potential to do a lot of public health good. So when I took these findings out to talk to people in the public health units, the first thing they said, this was actually pre-COVID, so I took my research around to the different public health units and talked to them, and they said, if there's a pandemic, this would be really useful to have set up so we would know, we could use it as an indicator of whether people are willing to accept vaccines or not. So, you know, thinking about that pandemic preparedness. And whilst I certainly hope COVID is a once in a lifetime event, I guess from an infectious disease perspective, I suspect there's a high likelihood that we could see more of these. There are a lot of emerging infections every year, and especially with climate change, it's really changing the environment, especially in some sort of more developing countries. That's really changing the environment and encouraging the development of sort of new and emerging diseases. So one thing that people said to me when I took this out was that they wanted to see that it was validated. So if we're using, I guess the next step Adam was talking about, sorry, Adam was the person who did the analysis. The next step he was talking about was using this information to actually predict people's, vaccine attitudes and belief. But then how do we validate that? So I'm really interested in running a study where we collect this kind of information from Twitter, but actually survey the people that were accessing their social media profiles to build a model where we predict their vaccination status, but then compare that to what they've actually reported. So a lot of the times when I talk to public health people about this, there's a big focus on the validation. There's still a lot we don't know about how misinformation is impacting people. Obviously, WHO has declared that we're in an infodemic, but how much that's actually affecting people is still really up for question. But I will say one thing that's happened in the US, in the UK, since COVID has happened is they have a media monitoring report. So just like you would see the COVID reports each week, we've had this many COVID case numbers, they actually have a report based on what sort of information is circulating online. So I guess that's something to consider. Would that be useful for Australia? But really, I guess now I'm kind of breaking off into two streams where one, I kind of want to investigate how misinformation is actually impacting people. It can, I think, sometimes feel very theoretical when we're looking at Twitter data or just looking at the data. But if people don't get vaccinated, some of those people are going to die. And I think that's a really important thing to remember, that this has real world implications for people. So I really want to look at the misinformation, but I also want to look at Twitter and other data sources to see how we might be able to improve public health practice. So when you see the COVID numbers being reported to the government, I think COVID's kind of a special case because obviously there's extra surveillance going on, but something like influenza, which kills a number of people every year, I just, as a computer scientist, don't overestimate the health department. There are very amazing, talented people working in public health, but there's not a lot of analytics going on in health departments. There are some exceptions. New South Wales is doing some good work. They have a biased statistician training program, and WA is, has been at the forefront of data linkage for about 15 years. But in terms of proper analytics, I don't want to make them sound bad, but I certainly know that, some of them are still using PDFs to collect information and then they have to re-enter everything. So using these new kind of methods is, I guess, a little bit scary for people, but basically the information they have at the moment is very limited. So if you have a case of flu, the health department will know that there's been a case of flu notified, but they don't actually know a lot of information about that person. And so it makes it hard to put public health measures in place if we don't actually know a lot of information. If we just know it looks like flu's increasing, but we don't know who it's affecting, it's really hard to target those kind of interventions. So I really want to see how we could use other data sources to really enhance that kind of information for public health people. And just finally, why is this important? So I think I've sort of highlighted that I think there's real population health gains to be made from this, and that's why I find it really exciting. And I guess I'm just really keen to work with people if they're interested. I guess from my experience in the last couple of years, and obviously being across a lot of the literature, it seems that a lot of work in this space very much comes from the heavily data science side or heavily the public health space. COVID, I think more people are dabbling, but it seems to me that public health people develop a program and then they bring computer scientists in at the end, or vice versa. So they're very heavily skewed. And I just think, especially in Australia, there is some very good work going on in the UK and the US, but I think we have a real opportunity here to build some really strong collaborations where we actually meet in the middle between, having some really cool computer science research questions to answer, but then also looking at them, what do we need to do to actually use that information to help people and improve health on the ground. So sorry, that's my skill, and that's hopefully what I would like to do in the future. Does anyone have any questions?
Can I ask,
Very good or very bad?
yeah, So like the other day we were talking about so what's the difference between like that topic modeling and the 5C models that Ash was talking about, like in terms of behavior wise, like have you looked at like positive information, like the effect of positive information of vaccine uptake? Like, could that be something like interesting or influential, like the way like misinformation is spreading? So if people are trying to spread positive information or positive side of the vaccine.
Yeah, so I think that's a bit more specific, and I think that probably comes down to the research question. So we weren't actually really trying to look at, I guess, the reasons, and that 5C work that Ash is doing is really looking at the different components of why people may or may not believe something. And so that's really more looking at the motivation behind why people will or won't get vaccinated. And I certainly think it's an important and interesting area. But this project in particular wasn't really trying to look at that individual level. How is this impacting people? It was trying to look from a public health perspective. Can we use this data to show us where we might expect low coverage regions to pop up? So I think it's just that different in research question as to how you develop the actual work. But I certainly think the work that Ash is doing is very important.
Yep.
And I'm happy he's letting me be involved.
Thanks.
Can I ask a question?
Sure.
Yeah, thanks for a great talk, Amalie. So the background, so it's often in the mathematical modeling community, the treatment of spreading of rumors or spreading of epidemics kind of has the same analytical tools. I mean, it's, you can use different mathematical models, different models to describe either spread of an epidemic or a rumor. Now here it seems like, there is some epidemic, we're putting a vaccine, but there is a potential rumors that are hindering the vaccine from being fully adopted. So I guess the question is if kind of in the new age public health disciplines, are we going to, do you envision that public health will model both the rumors and the actual epidemic and together, right? These things live together.
Yeah, that's my dream, Yoni. And look, I do think we'll get there. I guess, again, like I really just want to highlight there are amazing people working in public health, but I do find them to be, I guess, somewhat tech, I guess late adopters is what we would call them. And so I do think we'll get there, but I think at the moment, those kind of surveillance systems are seen as very innovative and they're research projects, and there's sort of one or two of them around. Having said that, CDC, so the Center for Disease Surveillance in America, so the largest public health organization, they have certainly started incorporating tweets into their like weekly reporting. But I would like to see that in Australia. But I guess, so what I did when I was in Sydney before I moved up to Queensland is basically went around and did a lot of stakeholder engagement. And I think the way that we need to convince public health people that this kind of information can be useful is to do some smaller projects which prove the utility and then bring them on board that way. Because currently when you speak to them, they sort of say, well, I don't even know what we could do or what the issues are. So I think having some small case studies would be important to try and get them on board. And certainly I know that the Google Trends stuff that Harvard's been doing, they've been doing it probably 10 or 15 years now. The health department wasn't interested in that at the beginning, and they just made the reports anyway and then kept showing them to them. And eventually the health department came on board. So I do think we have some work in the user end of this kind of technology to have it incorporated.
Thanks. Okay, very interesting.
So thanks, Amalie, for your talk. I have one question. Is there any research that shows how to deal with this thing? Like if there is an area that people are tweeting negatively about a vaccine. How can like health promoters deal with that?
It's a very good question, Ash. If I had the answer to that, I would be very famous. We don't really know. So especially the really hardcore people with the very strong beliefs, I guess we call them anti-vaxxers, we just don't engage with them, I guess, is the short answer. We don't know how to change their minds. And there's obviously a whole bunch of things that go into their thinking. It's certainly not based in evidence. It's more of a belief system, and it's based on trust and a number of other factors. I guess you've probably been reading about that recently. And really the research shows that if we present them with factual information, it makes them hold on to those beliefs even tighter. So we don't know how to address them. But I guess when we talk about vaccine hesitancy, those are the people that we really want to try and work with. So those are the people that are more in the middle, that might have heard of some of this misinformation and have questions or concerns. And really the main way to deal with those kind of people is to listen. So it's really important that, I think what happens if anyone asks anything about a vaccine, they sometimes can get shut down very quickly and they don't even feel like they've been heard. So taking people's concerns seriously and feeling like they've been listened to is important. And the other thing is, I guess in the social media space, I would say influencers, but I guess it comes down to that trust. So if there's someone that someone knows that they trust who has had the vaccine, you can use them as an example. But it's certainly, and there's certainly been reports of a lot of the influencers who have been pro-vaccination on their social media profiles getting a lot of direct messages asking questions about vaccination, even though they're not health professionals, purely because people trust them. So I think trust is really key link here.
Thanks.
I just have one more question about the social networks, and it might be also both to Amalie and to Ash. So, Twitter, we use Twitter, I guess, because the Twitter API gives us access, and that's kind of the Twitter model. But it seems like sometimes the questions we want to get are more of the Facebook style, simply because it's kind of, we want to understand local connections, right? So Twitter following doesn't mean an intimate connection between or a friend connection. And so the question is there some methodology to kind of infer from the Twitter data the closer knit real connection graph? And is that useful in this domain?
I don't know. I think it's an Ash question, but I think it's a really interesting question.
Yeah, so there are some works related to like matching the bios and also the location. So you have the metadata if they are really close, or also there are some methods related to if they talk to each other. So your network will not be the follow graphs. Your network will be people who talk to each other. And that won't necessarily be like a real world connection, but that's an influence connection, right? So if you
Twitter releases that data, Twitter tells us if people message.
No, not private messages, like tweet to someone.
Oh, okay,
replying,
like
having a conversation. Yes.
Yeah, I see. Right. Okay. So that's kind of a rough approximation. That's thanks.
So that can be used to infer location. Like if you talk to someone, so you can easily geolocate someone by finding out who they talk to. So like the average of the neighborhood is like where you are. Like you are where your friends are. So maybe other attributes, if there is this attribute of homophily, then you can identify attributes of that user.
Gotcha. Thanks.
So Amalie and I were talking about doing a similar experiment with COVID data, and Aminat is also involved. So yeah.
I think there's a lot of exciting work that could be done in this space. And I was talking to Aminat about it yesterday. And I certainly think while COVID has highlighted the importance of infectious diseases, this really has a lot of implications I don't think COVID's going to go away anytime soon, but it has very long-term implications in terms of vaccine-preventable diseases, emerging infectious diseases, and certainly in the adult vaccination space, we've got a long way to go in terms of adult vaccination coverage in Australia, which could really improve people's health. So I think there's a lot of work that could actually really help people.
So on my Twitter feed, I've seen people teaching other people to go to a doctor and say a fake disease that they have, so that the doctor prescribes a certain disease, a certain medicine that they think is good for COVID. So they're teaching each other these things.
There's a lot of dangerous information out there. Well, if anyone has any questions at another time, I'm always happy to talk, or if people want to email me, I literally will talk about this all day if anyone wants to.
All right, then thanks again, Amalie, and participants for joining us, and looking forward to seeing you in our next seminar.
Thanks, Amalie.
Thank you.
Thanks, everyone.
Thank you. Thanks, Ash. Bye.
Thanks.
Good job.